Welcome to AETCM, the emergency medicine channel. Today we are going to discuss a case about a 21-year-old male who came to our ER with complaints of left-sided shoulder pain associated with inability to move his left upper limb following a history of fall. Shall we, ma'am?
Yeah.
Ma'am, on initial 10-second assessment, the patient was conscious, oriented, was obeying to commands. Coming to the airway appeared patent and there was no pooling of secretions and the C-spine appears normal and he was walking to the ER. Coming to the breathing, air entry was bilaterally equal and respiratory rate of 18 per minute and saturation of 98% was maintained in room air. In circulation, the BP was 130 over 80 mmHg and the pulse rate of 90 per minute. He was complaining of pain with a pain score of 7/10 and all peripheral pulses were palpable. At that point of time itself, we gave him analgesis. Injection PCM was given, 1 gram IV was given. We secured one cannula at that point of time. Coming to the disability, GCS was full and pupil was bilaterally equally reacting to light. In the exposure wise, exposure was done and exposure and on an exposure itself, we found that his there was abnormality of the left shoulder. The normal contour was lost. For further adjuncts, we took an X-ray and X-ray of the left shoulder. AP view and lateral view was done, and it was showing an anterior dislocation of the left shoulder.
What type of anterior dislocation?
So in the shoulder dislocation and anterior dislocation has some types including subcoracoid, subglenoid, subclavicular and intrathoracic. The intrathoracic and subclavicular are the least common ones, whereas the subcoracoid and subglenoid are the most common ones. And here we got subcoracoid dislocation. And coming to the further survey, he's a 21-year-old male, has a history of shoulder dislocation 2 years back. And right now while he was playing basketball, he fell down on his outstretched hand and followed by he was having pain over the shoulder region and he was not able to move his arm. He came to ER within 15 minutes of the injury, and on arrival itself, on looking itself, he was holding his hand on with the other hands and it was near to his body. He was keeping near to his body, and there was no associated history of any LOC, vomiting, ENT bleed, seizures. And on further evaluation, we further evaluated him. Secondary survey, head and neck examination was normal, and in shoulder examination, on inspection,
you told that this patient came walking to the ER, so that we ruled out the C-spine injuries. What will rule in a C-spine injury?
C-spine injury, if the patient is complaining of C-spine neck pain, it can be of a C-spine injury. So we had to further evaluate for any chance of any tenderness, or if the patient is having paresthesia and numbness of the arms, or else if the patient age is more than 65, or else if the patient had a history of any severe mechanism of injury.
So first we need to consider the age more than 65, dangerous mechanism of injury, and any focal neurological deficits or paresthesia. We will have to consider a radiography of the C-spine. So you told dangerous mechanism. What is dangerous mechanism?
So dangerous mechanism is severe distracting injury with patient maybe like if the patient was moving in a vehicle and he might be thrown off, or if
thrown out of a car. Okay.
Then if the patient might be having decelerating injury, or if the history of any LOC or history of
if there is death of the nearby passenger, or if there is a fall from more than 5 feet height, or if it was any mechanism like sports injuries. Those are dangerous mechanism of injuries. Okay. So in this, if these three, anything is positive, we have to consider a radiography. then we will have to consider the rest, we have to rule out, if these are not there, we have to rule out a C-spine injury. So if the patient is having any delayed onset of neck pain, or if the patient is if that is not there, then that can be okay. Then if the patient is able to sit in the ED after some time, or if the patient is able to move rotate, if the patient is able to move the neck, or if it was a simple rear end motor vehicle accident, these things can, based on this, we will have to decide whether it is required or not. If more than one is positive, then we will have to consider doing imaging. If that is not there, that also is not there, then what will we do? We'll ask the patient to rotate the neck 45 degrees. If he is able to do that, then no need of any imaging. Okay. This patient, that was not there. So only shoulder injury. You are suspecting he is having a past history of shoulder dislocation. So now with recurrent shoulder dislocation. Okay.
So initially, we'll move on with the inspection, evaluation of the shoulder. On inspection, the shoulder was on comparing with the right shoulder. The left shoulder was little bit.
Before examination, what should you do?
You have to take consent of the patient.
Before examination, first we will have to confirm the identity of the patient. First we will have to identify. We will have to tell that we are going to do all this. For this, we will have to undress the patient. So we will have to get the consent. Then
we will be explaining the whole procedure and what all things we are gonna do to him, and also if what are the suspected differential diagnosis and what might be the complications of the same. So
and before starting an examination, we will have to ask for any pain and offer analgesics if required. Okay.
On repeating how was his pain, he said his pain reduced to 5/7 from the initial 7/10 of the initial pain. Okay. On then for further evaluation on inspection, on comparing with the right shoulder, his left shoulder was.
Where all should we inspect?
So, examination of shoulder, we have to inspect for the clavicle. From the sternoclavicular joint itself, we have to inspect if there are any changes there, and we have to look for any clavicular fracture. Then you have to look for the acromion coracoid processes. Then how's the humeral head, and how's the further down below also we have to examine for any other joint fractures, including the elbow joint and also the wrist joint for any other fractures.
So on inspection, first we will be looking the inspection. We will have to inspect from the front, from the side and posteriorly. From the front, we will be looking the alignment of the head and neck and the contour of the shoulder. Shoulder, how is it? How is the symmetry is? Then we will have to check for any obvious deformities, anything is there, any surgical scars, any sinuses or any wasting of the muscle. These things should be checked laterally and posteriorly also. So posteriorly, when we are checking, we will have to check for scars, any deformities or any abscess or anything present. Along with that, muscle wasting, whether it is there or not, and any obvious deformity. Along with the shoulder, we will have to examine scapula also. Any winging of the scapula, anything is there. So what will cause winging of scapula?
Serratus anterior.
So long thoracic nerve which is supplying the serratus anterior, if that is involved, there can be winging of the scapula. Then we will have to also check for the spine, C-spine, whether there is any kyphosis or any scoliosis, these features are there, or any wasting, there can be deltoid wasting or trapezius wasting. That also should be checked. Okay. Then what will you do after inspection?
Then we will go with the palpation. Have to look for here as it is as X-ray is already shown, like say shoulder dislocation. Have to look for the humeral head. Where is the humeral head located?
First palpation, always we will have to check for the temperature. Anyway, this patient we are not suspecting a infectious cause. Okay, temperature should be checked. Then before directly palpating on to the injured site, we will have to go from the distal area. So in front we will have to palpate the clavicle and go to the shoulder. If while examining the posteriorly, we will have to start from the C-spine. C-spine, scapula, scapular spine and the shoulder.
So here the humeral head was displaced anterior inferiorly, and clavicle, as already told, as normal. From then further we will have to evaluate for the neurovascular deficits. Here
what is the most common nerve injured?
Axillary nerve injury is the most common one. Here the all peripheral processes were palpable, and there was no loss of sensation or the axillary nerve region, including the deltoid, was also normal. Then
What is that sign called as?
Regimental.
Regimental
regimental
bad
bad
sign.
sign. So then we have special tests like Dugas.
Before going to special test, so inspection we have done, palpation we have done, all bony prominences including the acromioclavicular joint and the shoulder and the presence of the where the dislocation is we need to identify, locate. Then after that we will have to go for the movements. First we will have to ask the patient to do it by itself. That is what movement?
So here
passive
movements.
Then we will have to do it for the patient. That is active movements. Okay. So what all movements will you check?
So here at this case, patient was having pain. So we didn't go for asked him whether he is able to do it, and he having pain. So we never went for the movements of the same patient.
Okay. And if suppose if it is a normal patient, otherwise how will you examine?
So you'll have to ask with the movements of the shoulder, including abduction, abduction, external rotation, internal rotation. Then
How will you abduct the shoulder?
abduction.
How is the adduction done? Abduction and adduction done. First you'll have to show it to the patient how the adduction and abduction is done. So how will the shoulder be adducted and abducted?
We'll have to show it to the patient by we'll also have to raise our hand.
Sure.
Adduction, and then
When you are abducting, the hand should be extended. Upper limb should be extended, elbow should be extended, and then we'll have to ask the patient to abduct like this. And adduction, when we are doing, it should come down and it should go like this. This is adduction. How will we do external rotation, internal rotation?
External rotation, the arms are straight forward, then we'll have to internally
Flexed hand, upper limb should be flexed. This elbow should be flexed, and this is external rotation. And internal rotation can be done like this, and we'll have to keep our hand posterior like this. This is also internal rotation. Then flexion, extension. Flexion of, how will we do the flexion of shoulder? This is flexion like this. This is flexion, and extension is going backwards like this. This is flexion, extension. So abduction, adduction, extension, internal rotation posteriorly, then flexion, extension. Okay. Then this should be done. How? So why we are checking all this?
To look for any loss of any.
We are checking for any muscle involvement, muscle injured. So coming to the muscles. Mainly we are focusing on whether there is any rotator cuff injury. So what are the rotator cuff muscles?
Suprascapular, infrascapular, teres minor.
Supraspinatus,
infraspinatus, teres minor,
subscapularis. So where are they located anatomically? Supraspinatus is located where? Supraspinatus.
Near the spine of the.
Supraspinatus. Then above the spine of the what?
Coracoid.
Where is the spine? What has a spine? The scapula has a spine. Scapula has a spine. No. So supraspinatus is above the spine. Infraspinatus is below the spine. So where is the spine? Anteriorly or posteriorly? Posterior. So supraspinatus and infraspinatus is posteriorly. So infraspinatus, along with infraspinatus, one small muscle is there, that is teres minor. So everything is posterior. What about the subscapularis?
Below the scapula.
That is actually in front. Anterior. So supraspinatus is here. So what will be the action here?
Overhead abduction.
Supraspinatus is abduction. So the location is here, but so when it contracts, the shoulder will abduct. Okay. Infraspinatus and teres minor. They are posterior. They are posterior. So it will be doing external rotation. So who is the internal rotator?
Deltoid. Subscapularis.
Subscapularis is the external rotator. So we are checking the rotator cuff. Okay. Now we will move to the special test.
So we have Dugas test, Hamilton test, where in Dugas test we'll ask the patient to the injured region. We'll ask the patient to keep the injured hand over the opposite shoulder. How to touch the opposite shoulder. If most of the time, if the patient is having shoulder dislocation, it will be difficult for the patient to touch the opposite shoulder.
Why? Because the patient's arm is a little bit abducted and external rotated. Okay. What if it is like posterior dislocation? How will be the shoulder
So
attitude?
in posterior dislocation, the dislocation will be internal rotation, rotated and adducted.
Adducted position.
So patient will be having difficulty in that.
Fine. So he won't be able to touch the opposite shoulder then?
Then we have Hamilton ruler test, where we'll have to put a ruler over the olecranon process and the distal part of the humerus. If there is dislocation, it will be able to touch the olecranon and the humerus.
Okay.
Then for further, this patient will we given the pain medication and X-ray was taken. It showed dislocation of the shoulder and dislocation, and for further we will have to reduce the same. As the patient had a history of shoulder dislocation also, we initially for the patient is having pain, we
Give
did the analgesics, and for reduction of dislocation, initially we give procedure sedation, and then only we reduce the dislocation.
So how did you go with the procedure
sedation? Initially we'll have to take a consent for the sedation and also for the reduction, and following which we'll have to arrange crash cart, then cardiac monitor, ET-CO2. Also patient should be given O2 support. And if the patient is having no comorbidities and a young age, it was a no complications as a one type patient, and so further we after arranging for everything, we'll have to give analgesia, sedatives should be taken, and procedure sedation will be given.
Sedation with anxiolytic and analgesics should be given. Okay.
So in this patient we gave him ketamine and propofol, and here ketamine is given at the dose of 1.1 mg per kg, whereas propofol can be given like 0.5 to 1 mg per kg. And after giving these two, patients sedated, and
make sure that we are running an IV fluid also. Okay.
Because a patient propofol can cause hypotension, whereas ketamine can cause hypertension. So here we give this analgesic sedatives, and procedure sedation was done, and patient was this shoulder was reduced. So here procedure shoulder reduction can be done with multiple procedures. Most common like a modified Socrates method, and then we can go on with the Simpson's method.
What is Simpson's method?
Simpson's method is like a patient is lying in prone position with a weight lying in his hand, and as such there we won't need any active management. The weight itself will relax the muscles.
How much weight should we give?
10 kgs.
5 to 7.5 kgs. Okay.
Then it will itself reduce by within like 30 minutes duration. Patient's dislocated shoulder will reduce by its own. Then we'll have like Cunningham's technique, then Mills techniques. Then there is new ones like more Fair's technique is also can be used.
So what is the most commonly used here?
We are using coaches method for the traction, external rotation.
Traction, counter
traction. Then we'll have to externally rotate the
internal rotation and adduction.
External rotation, then adduction, internal rotation.
Okay. So how will we do that?
So here the patient should be lying supine, and traction, counter traction have to be done. So for counter traction, a helper will be there, and will keep a bed sheet or a otherwise we can long cloth, and we'll have to keep over his thorax region through the axilla and give counter traction
in the opposite shoulder.
So in that time itself he'll have to the examiner will keep the elbow flex to 90 degree, and traction will be given, and during that traction itself we'll
so traction will be given by the person on the affected limb, who is on the affected limb. Opposite side person will give the counter traction.
And we'll externally initially external rotation, then external rotation, then will be a medial adduction, then internal rotation will be then, and we'll look for whether we are able to touch the shoulder of the opposite side, and then we'll keep the shoulder after reducing to the side, and we'll put a sling over the
sling or a broad arm sling should be applied, and we'll have to send for X-ray. So before doing this test and after doing this test, what should be examined?
So we have to look for the neurovascular
status.
Initially also we will look, and after also we will look for any loss of any pulse deficit is there.
Suppose you don't have anyone to give counter traction, how will you reduce?
We can do with the coaches itself, without the counter traction. We can.
What is that? What is external rotation technique? External rotation technique is we can ask the patient to keep the upper limb flexed like this, and we can examiner can keep the left upper limb over the shoulder and feel for the reduction, and we are actively making the patient external rotate like this. So while doing this itself, the shoulder this thing will go back to position. So if we don't have any assistance, we can use this method. Then how will we do Milch technique?
So Milch technique is like patient is lying supine, wherein we'll have to there is also traction involved with the abduction, and we'll be moving the whole limb but at an angle of over 180 degree, wherein that movement will abduction will help in reduction of the shoulder to the glenoid.
Along with that, we will have to keep an arm over the axilla, and with our thumb we will have to push the humeral head back to the position. Okay. And different techniques as you told. Okay. So what happened to this patient then?
So after reduction, we did a repeat X-ray. Repeat X-ray was not showing any obvious fractures, and the shoulder which got reduced into the cavity, and following which we put this broad arm sling, and we gave him analysis and anti-inflammatories, and send him home to review after 2 weeks for further evaluation, and if needed to get a further imaging to look for any Bangart's or any Hill-Sachs lesion as a part of the shoulder.
Since it is a recurrent shoulder dislocation, we need to suspect a Bangart lesion or a Hill-Sachs lesion, whether it can be there, because that requires surgical management. So what is Bangart? Where is the Bangart lesion?
Bangart lesion is occurring in the glenoid cavity, whereas Bangart bony and non-bony can be there. Bony is in the cavity itself, whereas non-bony is in the glenoid labrum. Hill-Sachs is the lesion of the humeral head, which occurs due to the dislocation of the region.
Okay. So most common complication of shoulder dislocation is recurrent shoulder dislocation, and because of recurrent shoulder dislocation, these lesions can come. Okay. Thank you.